Welcome to Webinar Wednesday, everybody. I'm Carly Endries, Outreach Coordinator for the North Dakota Brain Injury Network. We hold these webinars every other Wednesday from 1:30 to 3, but they are recorded and archived for you as well. Once we're done today, I would say by the end of the day tomorrow, your CEU requests will be available in the same spot where you found the information to log in today, as well as the recording. So if you want to share it with anybody or pass the word along, you can do so then. Just wanted to say too that we have scheduled Web Wednesdays through July now. So pretty excited that I was filled up our summer almost. So make sure you keep joining us throughout the summer or keep coming back to watch later. And I think that's it for today. So I'm going to hand it over to Brian. He is with BrainScope and he's in Chicago. So take it away, Brian.
Thank you very much. So I'm happy to be here, and I really appreciate this opportunity to set up this meeting to just share this new technology that's available to everybody. And feel free to interrupt me if you have any questions, or you can also put them in the chat as well, and we'll try and catch those. But I won't bite, I promise. So just go ahead and interrupt me. I'd rather answer the question and make sure that your understanding of the technology is there. So I'll go ahead and get started. I am the rep for BrainScope here in the Midwest. So I cover basically the better portion of the central United States. So I am quite busy, as you can imagine, but I do enjoy it, and I am very passionate about these types of injuries. And now I'm excited to be able to present this and also join the BrainScope team, because this is something that I do believe will not only change care for the better when it comes to these types of injuries, but it's going to be more informative than the current practices, which is obviously the best of both worlds when you come out with a new technology, is to fill a need. So BrainScope is the first and only FDA cleared device to assess mild traumatic brain injuries, both bleeds and concussion at the point of care. It's really important to make sure that we are taking care of both of these injuries. And I can touch on this throughout the presentation, but largely some of the minor head injuries tend to go to the wayside, and those are obviously causing problems later on, and we want to make sure that we get to those right away. So I will get started here. So our company is a neurotechnology company here in the United States. We're in Bethesda, Maryland. We are pioneers in the use of AI and machine learning for the diagnosis of these types of brain injuries. Really what we're trying to do is, like I mentioned before, is give objective diagnostic insights really at the closest time to injury. Most of what you all are used to is you'll see a CT scan for a minor head injury, which isn't obviously ideal because it's not only dosing the patient with radiation or exposing them to radiation. 90% of those come back negative, but it doesn't do anything functionally. So that does prove to be a little bit of a challenge, especially in the ED setting, is they don't necessarily give the time that's needed even to do a neurocog or a proper assessment on the functional side. If they're negative, they'll go ahead and work on discharge. So really what we're trying to do here is just improve that process, but also enable this device to be used at the point of care and then give you objective data. Largely the subjective tests varies from clinician to clinician or even site to site. It may differ just based on who's giving the test. This technology isn't new. It's been around for about 10 years or so, largely within the military and the Department of Defense funded. We have 8 FDA clearances, 29 peer-reviewed studies. It's been well validated, so we know that the technology works. Obviously, if you want to think about why the military has been interested in this type of technology, is they're not exactly wheeling CT machines around everywhere where an injury would happen for the brain bleed piece. So this device is handheld and portable. You can see her holding the device here. It's about the size of an iPhone with a disposable headset. So it can be deployed pretty much anywhere. So if you're in the field of battle, or, paratroopers jumping out of an airplane, you'll be able to put this on in a field. So what are the current issues with MTBI diagnostic tools? We kind of talked about it just a few minutes ago with the head CTs are the standard of care, largely because there hasn't really been anything else available. But the CT scan has been used largely just to rule out the brain bleed. So the issues with that is 91% of those are negative. It also exposes the patient to unnecessary radiation. The wait times is something else that we're seeing a lot of now, is especially after COVID, where the really important piece is to separate the healthy from the sick, or to get patients out of there if they don't need to be there. So this is huge for that, because this assessment can be done in less than 15 minutes. And you can cut, anywhere from 30 to 40% of those head CT scans out. The other problem is the net average reimbursement for a CT is around $153. And then the obvious with the CT scan is it doesn't do anything for the concussion. So the other side of BrainScope, which is the functional, there isn't any standard of care. Everybody tends to do something different, if at all. There's multiple tests that are out there, VOMs, etc. Just a lot of different neurocogs, if they're even given in some of those cases. And they're inconsistent. And a lot of that's just because it really changes from clinician to clinician. One doctor might be comfortable with them and the other may not be as much, depending on what their education is. They're also largely subjective and they're easily cheated. This device reads brainwaves, so you cannot change or game the outcome of this, no matter how hard you try to think or do any of those things. It cannot be changed or gamed. So it's really exciting technology, because if you have, your 18-year-old, 19-year-old, 20-year-old who's trying to get back into the game, and he's going to try really, really hard to game the test so he can get back in the game, this will not allow it if he's not functionally there. Is there any questions so far? Okay, I'll jump on to the next slide. As I mentioned before, it's about the size of an iPhone. It's portable. I could actually show you guys here on my screen. It's built very ruggedly, obviously for the military. So it's been drowned, dropped out of airplanes, run over, everything you can basically think of, because obviously in those types of situations, the device needs to withstand quite a beating. So in an ED setting, we're actually getting a lot of positive feedback from folks that are there, because they're like, hey, I couldn't try to break this thing if I wanted to, and the ED is kind of a rough world. So we're very happy to say that it's very durable. We use algorithms and we use EEG technology, so there's no radiation exposure. We basically have algorithms that will read both the structural and the functional at the same time. So it's not that you're running two different tests, one test and then running another. They both run at the same time. So this is great from a time perspective, because you can go ahead and put this on and you can get that objective data, both structurally and functionally. Some of the physicians that are currently using this are liking this to D-dimer. If you all are familiar with that, it's largely being used as a pre-screening tool. They'll put this on right away to determine if further imaging is necessary. You don't need to read the EEG. It just tells you positive or negative for brain bleed. And then for the brain function index, it'll show you a scale. And I'll show you that here in a few slides. But largely, we get a lot of the questions around how reliable is this technology on missing a bleed. We are 99% sensitive to 1 cc of blood. So it's super sensitive. We will not miss a bleed. We have an outstanding negative predictive value of 98%. So when we say there's no bleed, there's no bleed. I can share a story that I just heard this morning. Actually, Inova Health on the East Coast, they were running scans last week, and they caught 2 patients that they were going to discharge that we ended up catching a bleed for. Both of them deemed what they would be considering insignificant because the bleeds were so small, but we were able to pick up on it. So that is huge. And then obviously we also provided the brain function index that showed that they were well below the average. So they were able to care for that patient further, making sure they're getting the follow-up that they need. Any questions so far? Okay. So, as I mentioned earlier, the concussion test can't be cheated. So, our brain function index, the brain waves don't lie. You could be under the influence of drugs or alcohol, and it will not impact the status of this assessment. So, I always joke with people, it's like if I were to put this on, I didn't get the highest grades in school, as opposed to somebody who did. If there is a brain function index, not so much based on intelligence, it would just definitely tell you one way or the other if there's something going on there. You don't need to be doing neurocognitive tests or anything like that. It just reads your brain waves. So this is what your two assessments will look like on the device, and then it'll also be printed out on a PDF for you. Right here, it's showing BrainScope negative on the left-hand side. That's likely no head injury visible on the head CT scan. So this patient, in this case, is showing a negative for a brain bleed. But as you can see, when it ran the brain function index, it's actually showing that they're well and clearly below the average over here in the red on the left-hand side on a scale of 0 to 100. So this is where we're really seeing this device shine right now, is even though these patients are negative for a brain bleed, it's still showing that they have a pretty large functional impairment and they definitely need some follow-up care. This is actually proving to be quite useful in urgent cares, immediate cares, and EDs, as normally they would discharge after getting a negative result, but now they're providing these patients with the functional assessment and really show the patient how badly their head injury was, even though there isn't a bleed. Excuse me. So our BrainScope's SIC accuracy is not affected by the presence of drugs and alcohol. So I mentioned that a little bit earlier. We are hearing that anywhere between 30 to 50% of people with TBIs are intoxicated, and about a third of those were under influence of drugs. So we do have a white paper on that that is available down here. It was one done by Ed Michelson. So if there's any questions on that, I can definitely email you all of that information as well. Our indications for use right now on the current device is ages of 18 to 85 within 72 hours of injury, and a GCS score of 13 to 15. I do want to point out that we actually just previously launched our AHEAD 500 device that has not only these indications, but we are now able to do a concussion index for the ages of 13 to 25 with no time parameters. So this is, as you can imagine, getting me a lot of phone calls right now, especially in the high school world where they want to get an objective assessment to make sure that these patients or these kids aren't going back into the game when they are clearly concussed. So there was recently a paper published in JAMA as well that showed the efficacy of our device and the dangers of returning to play before their brain is fully healed. So we are now able to do 13 to 25 and do that longitudinal testing to ensure that they are healed enough to get back in the game. So this is huge for our concussion index piece because now you can get an objective piece that's going to say you're not quite ready yet. So how long does it take? I get this question a lot. It's very, very quick. The prep to put it on, it takes anywhere from 2 to 3 minutes. I know it says 5 here, so they're kind of rounding up a little bit as how long it takes. Generally, it's very quick. The electrodes are simple. It will tell you exactly where to place each electrode. There's a little picture on each sticker. So it'll show you right above the eye, right here above the nose, and right here above this eye, and then the earlobes. All of these have the pictures on the stickers, on the electrodes, so it tells you exactly where to put it. To run the test, it's super simple. Once you get all of this set up, if you aren't fully comfortable, the device will walk you through all of these steps as well, or you'll have the option to skip it. If you're using this over time and you do get used to it, you can go ahead and skip the tutorial piece where it's walking through how to set this up on a patient, and then go ahead and start your EEG. Most EEGs are done in less than 15 minutes, and it provides both the structural and the functional. Depending on how cooperative the patient is, because it is EEG, if they are moving around a lot or talking or blinking or doing a lot of those things, there's some steps that we can do to help get the clean data. It's not going to skew the data. It just takes a little bit longer to get the clean data for us to extrapolate. So it's like I mentioned before, you can't game it. So even if the patient's not cooperative, it just might take a little bit longer to get your result, but nonetheless, it will get the result. Down here on the bottom, you can see the electrodes on the bottom right, what it looks like on the device when all of them are attached and operating. Yellow is okay. If it's red, we just ask you to remove the electrode and we provide a little scrubby just to kind of scrub the patient or exfoliate right there, and then go ahead and restick it, and it will go yellow or green, and it'll start running the test. We don't really run into any problems with these. Largely, they will be green or yellow right in the beginning. Very rarely do we get it unless the patient's like super dirty or has a lot of makeup or something like that. As I mentioned before, we are very well validated. We do have a lot of peer-reviewed studies. This one here in the academic emergency medicine, it's 99% sensitive for the brain bleeds. So this was a big one for us to get our FDA validation as well. Another test that was done is showing a significant reduction in head CT scans. So I can provide all these in a link if Carly, I don't know if I sent this to you, but if anybody needs that, feel free to reach out to me. I can send it to you so you have it. And then the drugs and alcohol piece I touched on already. So where are we seeing this?
If you want me to, I can link right to them when we post this too for the recording. If you want me to.
Excellent. Yeah, that'd be great.
Okay.
Yeah. So, and then you can also visit our website as well, brainscope.com. And that is going to have all of this information in there as well. Or you can reach out directly. Sometimes people don't like talking to me, so that's okay. Go ahead and you can look it up on the website. It's just fine too. We are largely seeing this most beneficial in the EDs, obviously, because of what I mentioned earlier. It fills a need both from the structural standpoint where they're trying to reduce the head CT scans, and then obviously providing the functional piece. And a lot of ED physicians that I work with, a lot of them really aren't doing much for the functional side. So they see this as kind of an added bonus that they can now provide their patient something that they weren't doing before. It doesn't have to be the ED though. I'm talking to quite a bit of rehabilitation centers, urgent cares, follow-up care centers that are working with me to provide this device as a referral tool to make sure that these patients do get to their sites when they do have a brain function index that's below the average. So we do see a lot of that as well. Over here on the left, this is a typical triage process. You'll see is the patient check-in, and it's labeled 1 through 11. This is based on the national average. When they implement BrainScope, it obviously cuts it in half of the amount of time and steps that are needed to discharge a patient. And that's what I mentioned before, why this device is gaining so much interest right now is because you can rule out a brain bleed and provide them a functional assessment and discharge that patient with more information than they had gotten if they were to get the CT scan, because the CT doesn't do the functional. So you can see where that would be beneficial. So the financials, I do get this question a lot as well. What we're seeing on not only reimbursements, but also the cost of the device and the care continuum on the referrals. I don't have exact data on referrals because it varies so widely from state to state. But I'm sure that there is some sort of monetary piece to a referral. I just can't really speak to that right now. But generally what we're seeing per patient, each headset that we provide, the disposable headset, costs around $200. the net reimbursement that we're seeing from the hospitals that are using routine CPT codes are on Medicare, Medicaid, pulling a little bit over $300 per patient. So you can see even on the lower end of the insurance scale, it's still providing a positive return. We also see the amount of time that's spent. I know I earlier mentioned 3 to 6 hours is what we typically see in a really busy ED for a patient to get a CT scan and discharge. It could be anywhere from $350 and up per hour in the ED for a patient waiting. So there's a monetary benefit to that as well. We're also seeing, increased throughput. So patients that would normally have to wait for a minor injury, they're seeing them get seen a lot quicker, just because now we can get the patients out of there that don't need to be there, and while providing more information. And we're also seeing huge improved patient satisfaction scores from this. So if any of you have had that experience where a patient would come in and you rule them out for a brain bleed and they'll tell you, that's great, but are you going to do anything for a concussion? Are you going to tell me how bad my concussion is, or anything like that? This device will definitely provide that. So now they know that you're providing them more information than what they would have gotten before with a CT scan. All right, that's about it for what I have. I want to open it up for some questions if there's anything that I can answer for you. I can also provide some other questions that I've gotten from some other folks if that would help.
Do you want to maybe explain to us like the FDA process, how that all went, or like what actually makes you FDA? Like what do they all? I don't know. Just explain.
Sure. Yeah. So it's actually quite extensive, to be honest with you. So the tough part about a new technology is that when you bring a device to market, they largely compare you to something else that's similar, right? So in this case, we had to provide quite a bit of information on the number of test patients that we've done, along with obviously the results, but we're predicated based off of a CT scan, which even though it's not the same technology, we had to get validated based off of something that's out there for the diagnosis of those brain bleeds. So in order to get our FDA clearance, we had to test up against a CT scan where they use BrainScope. And then they did a CT afterward to confirm the results. And that's where we got the 99% sensitive. It's actually important to know that during that validation study, the only reason we had 99% and not 100, we actually had one patient with the 1% where we deemed it as a BrainScope negative. And they went through the CT scan and they actually found an old stroke injury, not one that was fresh or new. So we were actually able to, because of our sensitivity, decipher between an old injury and something that had happened recently. So we're actually going to be printing another one this summer here with, I believe, Barnes-Jewish is helping us with this. And the data that we're seeing so far is 100%. So like I said before, we're very confident that, we're not going to miss a bleed.
Great. It's wonderful. What about, okay, so the device, once you have it, is $300 per patient. About what to obtain the device? What's that cost associated with that?
Yep. So pre-COVID, I can tell you that the device to get all of the assessments and just fully loaded is around $15,000.
Okay.
Now that COVID has hit, obviously we understand that money's tight everywhere, especially with capital budgets and things like that. We've launched what they call reference and feedback programs. So if you're a site or an ED, they will be placing these devices at no charge. If you're a urgent care or a rehab facility, the reference piece of this is we'll work with you on placing a device, and then we just ask for the referral to your referring ED. It's not a requirement for purchase. So we can sign you up for the program, and then you would just work with me to try and get the device into one of your local EDs where the volume would help justify placement of the device. So there's also no requirements on the disposable usage as well. So it's important. I do get that next question is there a minimum requirement for the disposables? The answer is no. You would need to buy a box of it just to start the disposable headsets, which are $200 a piece, and there's 25 of them in a box. But then there's no requirement after that. So if it took you a few months to go through it, that's just fine. It's not something where you have to hit a minimum.
Okay.
We are seeing the reimbursement piece from this too, on the CPT codes from a billing standpoint. Obviously, if there's a different site that's wanting to bill the patients directly, they can do that. I'm just privied lately to some of the hospitals are sharing some of their billing information with me just to show me, how they're doing it. And they're largely using routine CPT codes. But each individual sites, I am working with a few sites in Kansas right now that we did indeed place the device. It's a concussion clinic or a rehab clinic. And they're working on the referral piece with their referring ED. So they did qualify for the placement of the device at no charge. And then he thinks he's probably going to be able to go through 25 headsets maybe in the next 2 to 3 months. So
Any else? Any other questions, guys? Do you guys see yourselves using these or trying to get one for your place?
I do get a lot of questions on sports. So especially now that we've got the 13 to 25 validation,
Right.
a lot of people do see this on the sidelines. I can tell you here, I am based in the Chicago area. I am having a handful of conversations with some professional sports teams. So that's going really well. On a high school level, we are showing some interest here locally in the Chicago area as well. The piece that they're trying to figure out now is the billing part of it with the kids, the school district's budgets and stuff like that. They're trying to figure out who it is that's going to be paying for it. The other really cool thing about this device, it can do baselining if you want to, but it's not required. So even if you have a patient that's not baselined and you don't have previous data to go off of, you can still use this device to get that level of functional impairment. You don't need to go off a baseline from prior. So that is getting a ton of interest just because not everybody can get baselined before their season starts.
Right. So is there a different fee associated with getting a baseline, or is that part of the scan? Or
Sorry?
is it like a different fee to get the baseline, or is that just part of that?
Yeah, I mean, the fees will be a little bit different. I mean, obviously you're
Okay.
going to bill for that differently.
Sure.
So it's not as expensive as you're going to run the full battery,
Okay.
right?
Sure.
So there is a reduced cost to that. I can definitely find out what that is. I mean, this is so fresh, like on the 13 to 25 with the baselining piece. We're talking like a few weeks out. So
Okay.
I can get that information for you if somebody's interested in doing baselining. Definitely.
Okay. I was just curious. Yeah. Okay.
We're getting a lot of interest rural areas too,
I
because
could see
not
that.
everywhere has a CT scan. And with this being portable, I can tell you there's a number of very large health systems in the upper Midwest area that are looking at putting this on potential rigs or traveling physicians to be able to go out to sites or even nurses and go ahead and test somebody and reduce the amount of people that are transporting to the hospital if they don't need to be. So that's also another big one that we're seeing right now.
Yeah.
I think a lot of the telehealth is pushing that, where they're trying to get to the patient without having them have to come in, and they can
Right.
determine on whether or not it's necessary for them to get transported in.
And you said, I think when we talked before, you talked about nursing homes often use it, like if there's a fall, or is that a?
I'm sorry, you cut out just a touch.
Oh, if like a nursing home would use it as well too, like if there was a fall, like,
Y-
and you determine whether or not to transport from there too, right?
Yeah, so a lot of
Okay,
the ED physicians actually, I'm glad you brought that up. I did get that question last week too from one of the ED physicians. They have a nursing home. They that every fall that the patient has, they transport them to the hospital. They're largely negative for
right.
a brain bleed. So they're eyeing that piece as where they can get this into the nursing home and potentially reduce the amount of people that are transported to go get a CT. They're largely not as concerned about the radiation exposure at that point. It's more so from a just keeping the transports down. If they don't need to be shipped to the hospital, then they can go ahead and do this. Our specificity does drop a little bit for the older age range just because of shearing and previous injuries.
Right.
But when we're saying sensitive, again, we're not missing a bleed. So if you're putting BrainScope on and you're looking for anywhere from 30 to 40% reduction of them getting transported to the hospital for a CT scan, then yes, it'll definitely do that.
Very cool. Yeah, I think this is very interesting and very exciting for the whole brain injury world.
Yeah, it's great. Just because, I'm sure everybody's, probably had a head injury of some sort in their life. I mean, it's almost probably a given, but you'd be surprised how many patients, just because they're negative for a brain bleed, aren't showing a significant, level of functional impairment. Or we get a lot of times, and the ED docs too will say like, "Hey, we'll discharge somebody," and then a day or two later, all their symptoms just magically appear, right? And
Yeah,
they're like, if we would have put BrainScope on them in the beginning and we could have told it, hey, you're showing a pretty, significant level of functional impairment, you might be seeing some symptoms here over the next few days. It's not only going to help there, be a little bit more reputable, but also get that patient somewhere knowing that, hey, even though your onset of symptoms haven't hit yet, that you're likely going to get them because of how bad, it's showing. So
Hmm.
that is a big piece too.
Right, right. Yes. All right. Anybody else have questions? All
Any
right.
other ones that,
I don't see any, nobody in the
okay.
chat. Everybody's so quiet today. You did so good. That's a good, you just
Yeah,
talked
sometimes I just
everything.
rattle off things, but I don't give people a chance to ask questions sometimes, but hopefully we covered everything.
We got a very interesting thank you from Whitney. Yeah, and I like the military reference you made too. I think that's very important as well.
Yeah, and that actually comes into real life too, right?
Right.
So, a lot of times, those injuries, even though it's not structurally there, it doesn't mean that there isn't some functional things that could come back later in life too. And with it being portable, especially the more rural you get, the more areas this is going to be
Yeah.
transportable to catch those patients. Haven't had anybody ask me about the helicopters yet, but I'm thinking that at some point that's probably going to come up, although those are pretty significant injuries usually. So, you're probably transporting to a hospital anyway. But
Right. Sure. Yeah. Well, I think that's all we have, Brian. Thank you so much for your time, and hopefully we
depression, dementia, COVID brain. I did hear this one is something our R&D team is looking at. And then there's also one of the sites, and I didn't catch the name of it, but they're looking at resident fatigue and how that can affect them functionally. So there's a lot of future applications for the EEG technology, especially in the brain injury world.
Right. Great. Good. All right, last call for questions, guys. Oh, good question. Could this be used in the prison system?
Good question. Yes. Actually, it's funny somebody should mention that. My boss just informed me of a conversation he had last Friday with a prison system somewhere in the Midwest. He's based out of Michigan. They are also very interested in this from the transport side of things. So they can
Right.
go ahead and put this on them and deem on whether it's necessary or not for them to, save the transport to the hospital. Yes. That is something that an application that is being looked at right now.
Good.
And yeah, you're going to get pretty good results from that as well. So if your goal there is to reduce the amount of transport, then yes, this would definitely help for that.
Mm-hmm. Question, Sandy. And DBIN just got a grant to help with the criminal justice system. So we're hoping to implement screenings across the North Dakota system because the numbers are so high of TBIs. So yeah, this will be good information to pass along as well to them.
Yeah, and if you guys know anybody, that you think, whether it be an ED, urgent care, or somebody who works with MTBI a lot, if you wouldn't mind passing along my information, because again, it's just me. So by the time it takes me to reach out to everybody and let them know that this technology is available, it's going to take me a while.
Sure, definitely. Yeah, we can definitely help spread the word. Yeah, great. Okay, well, we'll let you get back to your day, everybody. Thanks for coming, and we have Brian's info, and so let us know if you need anything else, but stop recording.